All right, so we'll get started. Um, I'm going to introduce Dr. Larry Borsch. He is a doctor at UVA. He is phenomenal, and he has joined our Project Peppy team a few weeks ago, and we are so delighted to have him. He's going to talk today on sinusitis and immune deficiency. So I'm going to just go ahead and turn the tables over to him.
Great. And I'm trust everybody is seeing my screen okay. I love interruptions on the fly. Just shout out or put your hand up or whatever, but it's probably best to interrupt me and not wait to the end. I'm good with that. So I was actually a sinus doctor before I was an immune deficient doctor. I still do half day a week in the chronic sinusitis clinic. So I sort of bring that side to thinking about this to immune deficiency. Now, I'm going to read the learning objectives because I think they're kind of useful. But what I hope you all get out of this is an appreciation of when you should or should not worry about your recurrent acute sinusitis and your chronic sinusitis patients, to really appreciate that chronic sinusitis is an inflammatory and is almost never an infectious disease. And as a non-infectious disease, it usually isn't an immune deficiency, but then again, sometimes it is. So this is a case that we saw at UVA a few years ago. 42-year-old male. He came to the emergency room with one-day history of headache, new onset seizures. CT of his head was negative, but his CSF was pretty inflamed. And the those virus titers were negative, but he did have herpes simplex, and his MRI was a disaster, as shown here. But here's the thing. I actually got his records from Virginia Beach and from New Orleans before that. I couldn't count the number of times he'd been seen for acute sinusitis, at least 4 to 5 times a year, and this is for over 20 years. He had documented chest x-ray documented pneumonias in each of the years that I list here. And when the labs were obtained, he had unmeasurable IgG and probably had unmeasurable IgG for at least 20 years, and unfortunately had this horrible outcome. So let me start with comments on acute and especially recurrent acute sinusitis. Most people who claim to be having frequent recurrent acute bacterial sinusitis, in fact, aren't. Most of these cases, in fact, are, if they are an infection at all, they're going to be viral. And by viral, it means they reflect exposure to novel seasonal viruses for which immune memory provides no protection. Every year, nature gives us half a dozen new rhinovirus serotypes and coronavirus serotypes and every other, and previous exposure provides little protection. And conversely, having frequent recurrent viral infections reflects exposure and not an immune deficiency. Now, acute sinusitis can usually be pretty accurately diagnosed by the major criteria, which is you have pus coming out of the front of your nose and pus coming down the back of your nose. You have sinus pain pressure. We've all had acute sinusitis, and when we have it, we pretty much know exactly which sinus is infected. And then there's associated symptoms like cough. Fever is pretty rare in adults. Tooth pain can be referred. If an asthmatic, it can trigger that. Now, in contrast to acute sinusitis, we cannot accurately use clinical criteria to make the diagnosis. I have references here, but the bottom line is when compared with objective measures like CT scan and rhinoscopy, clinical criteria are actually little better than random in predicting the presence and severity of chronic sinusitis. So a few comments on chronic sinusitis. It is almost never an infectious disease. It is a self-perpetuating inflammatory disease of the upper airway. And with the damaged airway, and I'm going to talk more about that, bacteria are universally present. And when they're there, they are not innocuous. They are a source of antigens that the immune system may feed on. They produce all these toxins that non-specifically activate the immune system, including adjuvants and superantigens. And of course, they happily survive in biofilms. And being in biofilms they can be responsible for recurrent acute episodes. But the most common etiologies of chronic sinusitis, and by this I mean about 99%, one, and I'm going to show pictures of this in a moment, one is an idiopathic, non-eosinophilic inflammatory disease, less often associated with nasal polyps, and the other is an eosinophilic disease, which is pretty often associated with nasal polyps. So teaching point number one, the chronic sinus headache is an invention of Madison Avenue. And I can't be more profound about saying that. Migraines and sinus headache. I was taught in medical school that migraines were unilateral, but in point of fact, they are quite frequently bilateral. And since the pain is typically referred down the trigeminal distribution, the patients will feel the pain right over where the sinuses are, and that can be in the frontal area above the front, in front of the frontal sinuses, or in the maxillary area in front of the maxillary sinuses. Autonomic symptoms are incredibly common. 14% have nasal congestion and nasal drainage, 41% of ocular tearing, 46% have both. So you can imagine if you have a bilateral headache and a maxillary distribution, a blocked nose, runny nose, tearing from the eyes, it just becomes very easy to think that it's a sinus problem. The International Headache Society, however, states categorically that chronic sinusitis is not validated as a cause of headache unless it relapses into an acute phase. So this is a UVA study from a couple years ago. This was literally 100 consecutive patients referred from outside referring physicians for sinus surgery. And of those 100 consecutive patients, in 100 consecutive cases, literally consecutive, none of them had evidence for sinusitis, either by endoscopic exam in their nose and looking at the sinus ostia, or on their CT scan. The Lund-Mackay is a score of the severity of the sinusitis, and there just wasn't any. For 36 of these subjects, this was the cause that was identified after they were referred to a neurologist. I won't read the entire list, but 21 of the 36 had classic migraines, and then there were other causes of cephalgia symptoms. What's interesting is, in the world of sinus disease, we have, I think, one of the world's best acronyms. We measure sinus severity using something called the Sino-Nasal Outcome Test. That is the SNOT, and specifically the SNOT 20. And it's a validated test for sinusitis, but what's interesting is the people with a chief complaint of headache, that is the people who didn't have any sinus disease, they actually had the highest SNOT 20 scores, which just tells you how challenging it is to diagnose sinusitis, and that's chronic. So a couple other studies I just want to quote. I like this study because, again, of the numbers involved. 2,991 subjects who were referred or self-referred with what they thought was sinus headaches, and they did all these exclusions to make sure they weren't pre-screened for migraines. And these are the symptoms the patients reported. Now, I love this because if you look in the filled-in bars, you see the things that brought these people to a sinus clinic. They have sinus pressure, sinus pain, nasal congestion, runny nose, watery eyes, itchy nose. All things that sound like sinus symptoms. But when you actually pursue and ask people what the pain was like, 89% of them had pulsing or throbbing, 85% worsened by activity like bending over. Then you have all these classic sinus migraine symptoms like photophobia, nausea, phonophobia. 57% it was unilateral. And then you had 28% with an aura. And these are the diagnoses. And out of the 2,000, almost 3,000 patients, maybe 4% of them had any evidence of chronic sinusitis. So let me talk now about what chronic sinusitis actually is. These are pathological studies of people with non-eosinophilic disease. And what you see there is especially glandular hypertrophy, so incredible hypertrophy of the mucus-producing tissue. It's not shown in either of these, but you do see a lot of mononuclear cells, and you can see lymph nodes growing in these polyps or in the sinus tissue, a lot of scar tissue. What you don't see is a chronic infection with encapsulated bacterial organisms. And this is the other disease, eosinophilic chronic sinusitis. And you can see the sea of eosinophils in both of these, both in the higher and the lower magnification. And along with the eosinophil infiltration, in the top right, you see how the epithelial cells have been replaced by goblet cells. There's a swelling of the tissue. But again, what you don't see is a chronic infection with encapsulated bacterial organisms. And again, 99% of chronic sinusitis is just not an infectious disease. So why is there so much acute sinusitis in these patients? Because they may have a non-infectious disease, but they do get recurrent infection. And this will show up better in the next slide where I have the cartoon. But with the inflamed sinuses, you lose the barrier function, you lose the ability to clear bacteria in your mucociliary tree. There's a breakdown of tight junctions between the epithelial cells so the bacteria can easily slide through. You have that eosinophilic inflammation, most typically, as I showed in the last slide. And most importantly, part of eosinophilic inflammation, the same immune parameters that are driving the recruitment of eosinophils for reasons that I don't understand from an evolutionary viewpoint why it makes any sense, but it shuts down the natural production of antimicrobial proteins by the epithelium, and specifically antimicrobial proteins that you need to fight staph infections. So which is why, as I'll show you in a second, why there's so much staph in this disease. So here's the cartoon. Healthy sinuses in the top. You've got all those cilia on top that give you this beautiful mucociliary clearance. The epithelial cells are connected by tight junctions to keep the bacteria out. And you have these cathelicidins and beta defensins that are these natural mammalian antimicrobial proteins that are particularly good at killing staph. With chronic sinus disease, as you see in the bottom, the cilia are gone, the mucus just sits there and accumulates, and you have a lot more goblet cells, so a lot more mucus production. And that, of course, makes beautiful bacterial culture broth, which is what happens. With the loss of tight junctions, the bacteria can squeeze through, and thus the recurrent sinus infections. So this is an older study, but it's just pointing to the prevalence of staph in chronic sinusitis. And the abbreviations will make no sense to you, so I'll translate. Healthy controls, about 30% of them had some staph in their sinuses. As you know, staph just loves to grow in the nose and sinuses. Not much difference in the chronic sinusitis. That's the non-eosinophilic sinusitis. And eosinophilic disease, which is the nasal polyp people, or nasal polyp with asthma, the third and fourth bar, about 60% of them have staph. And the AS stands for aspirin sensitivity, that's Samter's triad, where virtually everybody has staph in their nose. So let me turn to a different topic of discussion that can be very confusing in the world of chronic sinusitis, which is the role of subclass deficiency. And I know Dr. Lawrence talked a bit about this in previous sessions, but to remind you, the definition is a significant decrease in one or more IgG subclass with a normal total IgG. It's not considered a true immune deficiency disease because as many as 20% of the healthy population have a subnormal level of one or more subclasses. And most people, most of those 20% are perfectly fine and have no increase in infection. What pollutes the literature was a statement made, I think, 20 plus years ago that you needed IgG1 and IgG3 for peptide immune responses, but IgG2 was critical for these polysaccharide encapsulated organisms like Haemophilus or Strep pneumonia, that is the bacteria that can cause bacterial sinusitis. But the idea that you need IgG2 for that is just no longer accepted. If you have IgG2 deficiency, as I like to say, the other subclasses are more than happy to take over for the absence of IgG2. So my bottom line is that I never check IgG subclasses, and the only exception I have to that is if I'm worried about someone having IgG4 related disease. Some more comments about specific antibody deficiency in chronic sinusitis. These are patients who have recurrent sinopulmonary infections, meaning they don't have that non-eosinophilic disease or that eosinophilic disease. They're having recurrent and they're not having recurrent exposure-related viral infections. These are people having recurrent infections with encapsulated organisms. They will have, because it's specific antibody deficiency, normal IgG, A, and M. And then the diagnosis is based on their inability to respond with antibodies to immunization, and that immunization needs to be done with polysaccharide vaccines. And again, this is something that I know Dr. Lawrence discussed in one of these previous sections. So you can't look at the response to Prevnar. Prevnar is too good a vaccine, and even immune deficient patients will respond to Prevnar. It has to be the Pneumovax. However, the normal values for specific antibody responses to polysaccharidated vaccines are actually not well established, which gets into what I call some of the fun facts about specific antibody deficiency in chronic sinusitis. As I already said, the most common bacterial infections these patients get is recurrent staph and chronic staph, but also recurrent acute staph. We also see a lot of gram-negatives, Pseudomonas and other gram-negatives. The problem is, in terms of the immune response to staph and gram-negative organisms, that is, the immune response, almost never involves antibodies in healthy people. We have other much better ways of getting rid of staph and gram-negatives that don't use antibody optimization. There are no antibodies to either staph or gram-negatives in the immunoglobulin replacement therapies. Number one, even healthy people aren't making antibodies, but the point is these are healthy people. They're not people who've had invasive gram-negative disease or invasive staph. So they would have no reason to even have antibodies to either of those. So immunoglobulin replacement therapy for those organisms would be worthless. Therefore, don't test for specific antibody deficiency in patients who in fact have staph or E. coli or other gram-negatives or Pseudomonas in their sinuses. What they are infected with is the encapsulated bacteria, Haemophilus strep pneumococci, and those are the infections that you want to document. So, comments on the usefulness of polysaccharide immune response testing in specific antibody deficiency. And again, I know Dr. Lawrence talked about this, but Pneumovax is a crappy vaccine for most people. It's a crappy vaccine, but it's actually what makes it somewhat useful in testing for a deficient immune system. But because it's a crappy vaccine, it's being replaced with the Prevnar 20, which as a protein conjugated vaccine cannot be used to assess immune deficiency, because even people with often very advanced immune deficiencies will make robust responses to the Prevnar vaccination. So, as I said earlier, the normal response to Pneumovax is not well known, and I love to make this sort of sarcastic response to some of our medical students and residents using the strict application of published criteria from the Clinical Immunology Society, and I put the reference down here, for what constitutes a normal response to the Pneumovax. Anywhere from 20 to 50% of healthy controls may be considered non-responders. So the joke bottom line I give is you can't treat specific antibody deficiency with immunoglobulin replacement therapy, since pretty much all the healthy donors seemingly have specific antibody deficiency. So I'm giving you a really confusing discussion, but I'll give you a sort of a cartoon here on how I think you need to think about this. So in someone who you're worried about immune deficiency, evaluate for the presence of comorbidities, first of all, leading to increased susceptibility to infection, and maximize medical treatment of these conditions. That is, if they have underlying allergic rhinitis, the inflammatory sinusitis that I talked about, as in the case of lower airway infections, asthma, COPD, cystic fibrosis, manage that as well as you can. But to me, the most important part of thinking about immune deficiency is establishing microbiological evidence of these encapsulated infections. In English, this means you need to find your local neighborhood otolaryngologist and make him or her your best friend, because you have to diagnose that these are not viral infections, or for that matter, not migraines or other cephalgia. We have these patients who come to our clinic with this story of recurrent acute sinusitis. And the one thing we always do is arrange that we will see you the day of or the next day, or certainly within 48 hours of the onset of infection. And we want to see you that day and document what bugs you have. And these are the people who you're really worried, maybe this is an immune deficiency, and get a proper culture and prove that the infection is with one of these encapsulated organisms. And only after you've documented that it's Haemophilus or strep or pneumococcus, then do you do the evaluation for a humoral immune deficiency, where you use the lab testing that I've just talked a little bit about, and I know Dr. Lawrence talked about, in terms of the response to the polysaccharide vaccine challenge. So last little bit I'll mention common mistakes in the diagnosis of common variable immune deficiency. So CVID is not a patient with normal IgG and what is called a decreased response to vaccinations. Again, because the normal responses are really not robustly defined, and a lot of healthy people have these decreased responses. You have to document the recurrent infection with encapsulated organisms. It is not a person with a slightly low IgG level who is currently on or has recently been on chronic or high doses of corticosteroids. That's a normal response. It is not a low IgG subclass level, and it is not a patient with chronic sinusitis. That's an inflammatory, non-infectious disease. And it's not a patient who feels better when treated with IVIG. Everybody feels better when they're treated with IVIG. It's great to walk around with antibodies to everything that infects North Americans and never have to worry about getting sick with those organisms. Some final teaching points are: one, getting acute, typically viral sinusitis a few times a year is normal. The most common cause of recurrent acute sinusitis is underlying chronic sinusitis. Only think about antibody deficiency with multiple infections in different target organs. I didn't talk about that, but as I often will tell patients, when you're immune deficient everywhere. And those conditions, the quip I use, it's whack-a-mole. You're treating sinusitis one day, ear infections another day, bronchitis, pneumonia. You're just constantly fighting infections in different target organs. It's not a disease that only affects the sinuses. And the final teaching point: most patients concerned about immune deficiency actually aren't immune deficient. Most patients with immune deficiency, however, aren't concerned, nor, unfortunately, are their doctors. These patients are going to you all, and they're not getting referred to the primary immune deficiency clinic. My bottom line is only you can make this diagnosis, but only if you think about it. And with that, I'll conclude my formal remarks, and hopefully, I see a couple comments in the chat box, and hopefully people will also interrupt.
Does anybody have any questions for Larry?
I'll lead off. Larry, thank you so much for this great talk. And I really appreciate your points specifically around chronic sinusitis in isolation, not necessarily being an identifier of primary immune disorders, but certainly when taken in the context of other infections, is something to worry about. I love that. I also really loved your point about specific antibody deficiency. I wondered if you could just speak a little bit more broadly about antibody quality differences and deficiency, because we do think about antibody deficiency patients both in insufficiency in quantity, which you spoke about, low IgG example, but also insufficient quality. And you mentioned typhi, and I know that Dr. Lawrence did as well. Could you talk about how you think about assessing antibody quality?
Well, I sort of glossed over the salmonella, and it's probably worth repeating, just because the big point she was making with the Prevnar 20 taking over, it's really taken away our ability to use the Pneumovax test. Even when used correctly in the person with documented infections of the upper and lower airway with encapsulated organisms, and a normal IgG, and all of a sudden you've had the Prevnar 20 and the response looks great. A comment that I don't think a lot of people fully appreciate is how good the vaccine industry has gotten at getting an immune system to respond. And you can correct me if I'm a little off in my percent, but you can have people with absolutely full-blown, unambiguous common variable immune deficiency and a barely perceptible IgG level. And if you give them one of these RNA vaccines for, say, COVID, I think the statistic is 70 to 80% will make an antibody response. Meaning you may have, I'm joking now, you might have 3 B cells that are still alive and functioning, and with a RNA vaccine, they'll respond to it. And the encapsulated Prevnar vaccine is the same thing. It can't be used to test for immune deficiency because it'll find that one healthy B cell you have. So historically, we loved the Pneumovax just because, as I glibly said, it's kind of a crappy vaccine. But at least you could look at the 23 responses, and it was hard to interpret, but your response is 0 of them. That was pretty compelling, and 23, the debate that you and I will, and our friends who are immunologists respond is that middle ground where nobody knows where the cutoff is. But Monica talked about the salmonella test, and I can share that with people because I love the salmonella test. This is the vaccine that you all give to people who are traveling out of the country, or going up the Amazon or going up the Nile, and the place where the typhoid is an issue. And the beauty is, first of all, most people have not been exposed, so the baseline is incredibly low, and you can look at a response to this sugar-coated vaccine, and you get a 2-fold or greater response. That is very compelling evidence for the fact that you can make, as you just said, Dr. Ryder, quality antibody responses. And if people have more questions about how to use the salmonella test, I'm happy to share, or Angie is happy to share my email, and I will definitely get you the information on how that test is ordered.
That's great. Thank you for that response. Fantastic. Any other questions?
All right, so I guess since we don't have any more questions, we'll go ahead and wrap it up. I wanted to let everybody know that we now have a YouTube channel. It's I Echo Peppy on YouTube. That way you'll be able to go back and see any videos that you missed, or because I know some people are starting now, jumping on, that haven't been with us from the beginning. So go ahead and you can watch any videos that you want. You can also access our chat session. If you go to the iEcho website, there's a discussion board. You can get in touch with us at any time. June 25th, Dr. Ryder will be back on, and he is going to go over a case presentation. It's going to be very interesting. So if no one has anything else, I'll go ahead and end us today, and we will see you back on the 25th of June.
Okay. Great. Thank you all for joining. Appreciate